Today we'll be discussing about rhinosporidiosis. What is rhinosporidiosis? I'll be discussing mainly about the nasal rhinosporidiosis. So rhinosporidiosis is a chronic granulomatous infection of the nose. It is caused by an organism known as Rhinosporidium Seebri. What is granulomatous infection? In granulomatous infection, you can see granulomas in the histopathology. That is due to the chronic inflammation. There is accumulation of the immune cells, especially macrophages, in reaction to the chronic inflammation. So scientists have been doing different studies to classify this Rhinosporidium seebri taxonomically. Some say it is fungus, some say it is protozoa. Microbiologists say it is fungus because it stains all the fungal stain like PS, methenamine silver, mucicarmine. It stains all the stains. But now after various genetic sequencing and due to its aquatic nature, it is told as a aquatic eukaryote and it is identified as a fish parasite, a Nesomycetozoa belonging to DRIP clade. If you are interested in the taxonomy classification, all that, you can look into it. But rhinosporidiosis, chronic granulomatous infection of the nose caused by Rhinosporidium seebri. Where is this infection seen? So the infection is most commonly seen in tropical and subtropical areas. What is tropical and subtropical areas? These areas are near the equator. Example, our country, India. So it is near the equator. So we have hot and humid climates and we also receive a good amount of rainfall. So this organism also prefers this kind of climates. In Asia, mostly it is seen in India, Sri Lanka. In India, it is seen in Tamil Nadu. Tamil Nadu is an endemic area. Pondicherry, Puducherry, then Kerala. It is also seen in Chhattisgarh, Madhya Pradesh, Punjab, Haryana, etc. Nowadays, everybody is traveling, everybody is everywhere. So a person from Tamil Nadu can go to UK and a sporadic case can be detected there. So a person, a doctor or an infectious disease specialist working there should have this rhinosporidiosis in mind if a patient is traveling from an endemic area. In Tamil Nadu itself, if a person is coming in Chennai, if he's coming from Nagarjuna or Kanyakumari, it's a more chance that he has a rhinosporidium infection. How do you get this infection? This rhinosporidium is seen in the water. It is known as aquatic eukaryote. So it is seen in water, in ponds, stagnant water. If you take bath, it can infect your nose. Rhinosporidium seebri also infects dogs, cattle, everything. So if in a village or an area where humans and cattle and dogs, everybody is using the same pond, there's a more chance of getting infected by Rhinosporidium seebri. So the most common theory is that is direct contact. You get a dip in the pool and the Rhinosporidium seebri is coming into contact with your nasal mucosa. Usually there should be little bit traumatized nasal mucosa and it needs a wet surface to get attached and proliferate. So it will get attached to the nasal mucosa and you will get infected. Other method of infection is auto-inoculation. That is, if your nose is infected and you are picking the nose and all that and touching your eyes can also get infected. And if you're touching another person's eyes, that person can also get infected. And also, this disease can have dissemination, that is spread via the blood or the lymphatics. So hematogenous and lymphatic spread can occur. Some studies say that there's a genetic susceptibility to get infected with rhinosporidiosis. That is, certain HLA blood type people can have more chance of getting infected with rhinosporidiosis. So where does it affect? The most common location is nose. 50 to 58% of rhinosporidiosis affects the nose. It can also involve the nasopharynx. It can involve other structures also, lips, soft palate, larynx, trachea, bronchi, the genitals, the respiratory mucosa, eyes, everywhere it can be involved. So the rhinosporidiosis is generally classified based on the location it involves. Nasal, nasopharyngeal, mixed involvement, mixed nose and nasopharyngeal involvement. Busier involvement, that is involving the ocular or genitals. Then fifth is malignant rhinosporidiosis, that is not malignancy, cutaneous involvement. So disseminated rhinosporidiosis is known as malignant rhinosporidiosis. Previously, studies have shown a male predominance in the rhinosporidiosis because males were more actively participating in the work related exposure to rhinosporidium, like bathing in ponds, agricultural work, or a river sand miner. So the patient will almost always have a bathing in pond history. But now the male preponderance is coming down. Recently, I came across a 10-year-old child came to the emergency room with sneezing blood. She had 2-3 episodes of sneezing and blood was coming out from the nose and a chunk mass. Mass was also extruded along with the sneezing. Histopathology of the mass was shown to be positive for rhinosporidiosis. So such cases are also being reported. What is the usual presenting symptom in endemic areas? That is, what's an endemic area? Endemic area are places where the disease is almost always present and it almost always affects the local population. So in endemic area, it can be a incidental finding also. When you examine a nose of patient, you can see a mass. Other times, the most common complaints are nasal block, nasal discharge. The nasal discharge can be blood-tinged nasal discharge. A patient can come with frank epistaxis also. On examination, you can see a polypoidal friable leaf-like mass. The mass is usually attached to the septum or onto the inferior turbinate. When you try to probe, it usually bleeds on touch. And the surface of the mass will have small spots or studded with yellow or white spots and bleeding points. So that gives it the strawberry appearance. That is how we describe the rhinosporidiosis mass. Also, the rhinosporidiosis can involve the nasopharynx, and on an oral examination, you can see a mass that is hanging down behind the soft palate. What are the other differential diagnoses? It can be any infected nasal polyps, nasal papilloma, any angiofibroma, carcinoma of the nasopharynx, etc. If the mass is involved in the nasopharynx, and also tuberculosis, you have to rule out tuberculosis. So what are the investigations that can be done? You can do a general blood investigation, but usually in rhinosporidiosis, the blood counts, total WBC counts, everything is usually normal. We can also do a CT-PNS to find out the number of lesions, to find out the location of lesion, the extent of lesion, any involvement of the nasolacrimal duct, any bone involvement, etc. The final diagnosis is by histopathological examination, mainly because this organism cannot be cultured in the lab. Also, this organism cannot be inoculated in the lab to experimental animals. So the final diagnosis is by HPE. So before explaining the HPE, I will explain the life cycle of this organism. So the main component of the life cycle of the organism is endospore. From endospore, the organism develops to release the endospore and it gets infected. That is how the cycle goes. So there are three stages. First stage is a trophic stage or a trophozoid stage. It is a juvenile endospore. So that's a small endospore. So small endospore with the clear cytoplasm, vesicular nucleus and nucleolus, it starts dividing. It starts dividing into bicella stage, 4-cell stage, and it starts dividing into multiple endospores. And that is known as trophozoid. The trophozoids becomes big and filled with numerous endospores. Then there is development of sporangium. A mature trophozoite is known as a sporangia. The sporangia contains around 12,000 to 16,000 endospores. And once the sporangia matures, it develops germinal centers where the sporangia breaks and releases the endospore. That's the third stage. That is the release of the endospore. The germinal center can break and release the endospore. Also, the sporangia can burst, releasing the endospore due to the pressure. When the endospore is released, the endospore will carry with it the mucus and the secretion from the sporangia that gives it a comet-like appearance. That is known as comet of Beatty, which is identified in the histopathological examination by PAS stain. So that is important. So this released endospore is a final infecting particle that is also known as electron body. So this goes to the other structures and get infected, or this can travel via the blood or the lymphatics and spread to the other place. So trophozoid endospore divides, forms the sporangia, and sporangia ruptures, releasing the endospore. All this can be seen in the histopathological examination. So when you see the slide of the histopathology, you can see the sporangium in different stages of maturation and release of endospores, comet of Beatty, electron body, etc. can be seen in the histopathology, which is confirmatory for the diagnosis. Along with the spores and sporangia in the submucosa, there will be associated chronic inflammatory infiltrates like lymphocytes, macrophages, polymorphonuclear cells, etc. One striking thing that has been identified, eosinophils infiltrate are not commonly found in rhinosporidiosis. Also, you can do a PCR testing to identify the genetic material. What is the treatment? The treatment is excision. So complete excision of the mass with cauterization of the base. But there are chances of recurrence of the lesion. The problem of recurrence is mainly due to chronicity. So somewhere or the other, the endospores will be circulating. The endospores have thick chitinous wall. The endospores and sporangium has thick chitinous and cellulose walls. So double layer walls. So the problem is there is antigen sequestration. That is, if the body has to attack an antigen, like the army of our body has to recognize that there is a foreign body inside our body to attack and kill it. But because of the thick wall, the antigen is not presented to our immune system. So our immune system takes time to find it out and react. And also because of the wall, it somewhat prevents the immune destruction. There is also antigenic variation that causes the complication of recurrence. Even after surgical treatment, cauterization of the base, electrocautery excision, nowadays we use laser excisions also. Then there is also chance of dissemination, especially if you're immunocompromised. Then another problem is there are not many drugs that are effective for Rhinosporidium seebri. The only drug that is used is dapsone. Dapsone you have to give 100 milligram per day for 6 months and years together. The patient has to take treatment, especially in endemic area. And this dapsone can cause other side effects like granulocytosis, methemoglobinemia, hemolytic anemia. So every 2 weeks you have to check the liver function test of the patient when the patient is on dapsone treatment. A word on cutaneous rhinosporidiosis. The cutaneous rhinosporidiosis can be three types. That is satellite lesions. That is, you have a rhinosporidiosis in the nose, and then the rhinosporidiosis is spreading to the nearby skin area. Then there can be hematogenous spread of the endospores causing cutaneous lesions. Cases of primary cutaneous rhinosporidiosis are also reported. Cutaneous lesions are usually seen as warty papules or nodules with whitish spots. So, if a rhinosporidium patient, you have to examine the body for any cutaneous lesions before you start the treatment.